B mode, almost all the major anomalies of the heart would be ruled out. So this is a very good view, very good way of screening for fetal heart. So here we have the ductal arch, here we have the aortic arch, and both of them are almost equal in size, maybe slightly larger, but both of them showing, and here it is going away from the heart. Okay, so now we will look at the four chamber views in a little more detail. So we have now the four chambers there, and okay. So basically, when I take a sweep, I'm just going from the abdomen, coming up, 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 up. I'm not tilting to any direction. It's a sweep. Sweep is this way. That's a sweep. This is known as a sweep technique. Okay. So now we'll look at a four chamber view in a little more detail. So the baby is very cooperative. So the baby has changed the position for me because I wanted to demonstrate the four chamber view. Very nice baby. Acha baby aapka. And then so we have the four chamber view here, and we will just identify the chambers. Some important landmarks when you're looking at four chamber view. The rib, this thing has come in between. Yeah. Okay, now can you make it big, zoom, zoom. Okay. Okay, so as Joyti said, we have to magnify so that we make sure that we have one rib on around it. I can see one rib, that means I am not in an oblique position. Okay, so here we have four beautiful four chambers. We will just identify the chambers and then move into the loop again. Okay, so this is the aorta, this is the spine. So this is the descending aorta. As she said, the chamber which is closest to the descending aorta is the left atrium. Okay, the chamber which is closest to the sternum is the right ventricle. Therefore, this is the right atrium. This is the left ventricle, which is, I call it clean shaven. Here we have moderator band, so it's very dirty looking, right? This is very clean looking. Women like men who are very clean shaven, right? Maybe. So you can also appreciate one more thing, and that is if you look at the leaflet of this tricuspid valve as compared to the mitral valve, is there a difference? This is definitely low. So this is known as an offset valve, which is the tricuspid valve. And as Joyti said, the valves and the ventricles are loyal to each other. The tricuspid valve will always drain into right ventricle. The mitral valve will always drain into the left ventricle. The valves are always, they show loyalty between them. But the atria may not always be loyal. So we can have something like corrected where you might see that the atria are wrongly placed. So that's our normal four chamber. We are seeing good contractility. Another very important thing is the flap of the foramen oval. So that's the flap of the foramen oval, which you can see that we know that the flap of the foramen oval opens from the right side into the left side. So can you appreciate that opening of the flap of the foramen oval? We can also switch on color there, and we can see the flow across the flap of foramen oval. Yeah. Little less because I'm in the flap of foramen oval. Yeah. But as Joyti said, we have two things. The coronary sinus should not be mistaken for flow across the flap of foramen oval. Okay. So both the atria are of equal size, which is what we expect. We are seeing a septum primer. So this is what we need to appreciate. That's the septum primer. Okay, there. So when we look at atria, both atria should be same size. We should see the septum primer. We should see the flap of foramen oval, and that should open with a normal direction of flow from the right atrium into the left atrium. Another very important thing when you look at the atria is to appreciate the pulmonary veins. So here we have the two pulmonary veins. We see the inferior pulmonary veins, and as Joyti said again, they are they sort of hold on to the atria. So they sort of pull the atria, and with the result that usually this wall of the atria is very taut because there are pulmonary veins which are sort of holding on to that. And the distance between the aorta, we see some distance between the descending aorta, thoracic aorta and the left atrium, which is quite normal. Okay? And then so we have looked at the atria, we look at the ventricles, and again we look at the morphology of the ventricles. We appreciate that the left ventricle looks bigger Why does it look bigger? Because it is clean. So we can see the apex of the left ventricle. The apex of the heart is formed predominantly by left ventricle. Actually, more or less, both are equal in size, but we feel that the left ventricle is bigger because it is elongated. Whereas the right ventricle is sort of pyramidal. We have these moderator bands, and as we said, it is closer to the right atrium, to the sternum. So both ventricles are normally more or less equal in size. We can eyeball. One of the most important signs of a cardiac anomaly is a disproportion between the ventricles. If you see the ventricles are disproportionate, that's the you should think of some anomaly. Now you can sometimes you want to measure the ventricle a bit, and what we do is when the valves are closed, we just go below the level of the valves and measure the width of the ventricles. Can we have the measurement? Sorry. But where is the mark? Okay. Huh? Yeah, measurements. 1 minute. I'll come back to that. Oh. So before this fetus changes his mind, I want to demonstrate everything. Yeah, okay. Okay, yeah. So with the valves closed, we take the measurement, we take the width. Yeah, take the width. LV diameter. Okay. So we take the width just below the level of the valves, and then we have what are known as Z scores for each gestational age, and that will tell us whether the weights are normal. And we can also take what is known as the RV to LV ratio, which generally is a good sort of a way of finding out if there is a ventricular disproportion. So this ratio is usually in the range of 1 or 0.9. If it goes like 0.6, 0.5, then we know that there is a ventricular disproportion. So having looked at both the ventricles, the very important thing we need to look at is the interventricular septum. And the best way of looking at the interventricular septum is to look it head on. As Joyti said, when you look at it in a perpendicular way, we look at the entire interventricular septum. It is thicker in this area, it is thinner in this membranous area, but you can see that it is quite intact. And in this view, if I switch on color, even if there is a small BSD, I will be able to pick up. So we go almost in a lateral four chamber view and then switch on color, and we can see that there is no color going from one side of the ventricle to the other, telling us that the ventricles are normal. Okay. So this is about the four chamber view. Then we needed to look at the outflows. Okay. So now what I'll do is from the four chamber view, I will tilt my probe to the fetal right shoulder. And when I do that, I get the left ventricular outflow tract. Shoulder, that's right. Left side, left LVOT goes to fetal right shoulder. So again, what we see here is two important things. One is what is known as a septo-aortic continuity. So the ventricular septum continues here. The leaflet of the mitral valve and the aorta, they are very close to each other. And this is a very important finding which we need to always look at. So again, I will go into the four chamber view, and this fetus is really cooperative, and I am now getting the left ventricular outflow tract. Okay. So when I wanted to look at interventricular septum, it turned so that the interventricular septum is towards me. I wish all Indian feta were also like that. And then when I want to go into the right ventricle, I will just turn on the other side and I see the right ventricular outflow tract. Now this lateral four chamber view is an excellent view to see this crossing. Can you see the crossing? There is a left ventricular outflow tract, there is a right ventricular outflow tract. They are crossing each other. That rules out most of the outflow anomalies where there is an overriding of vessels. Okay, so I can see the crossing of vessels, left ventricular, right ventricular outflow tract. Now I want to see the entire right ventricular RVOT. So what I'll do is again go into the four chamber view and take a short axis view, and I can see a beautiful right ventricular outflow tract. Okay, so we can see the entire right ventricular tract. That's the okay. Here we are. That's the right atrium, right ventricle. That's a pulmonary valve. That's a pulmonary artery, and we can see the bifurcation of the pulmonary artery, right and the left pulmonary artery. And here we have the descending aorta. This view is a short axis view where the pulmonary artery sort of goes round the aorta, and that's again a very important view when it comes to outflow anomalies. So now if you see this view and we see a good LVOT, that means most of the times there is no going to be an outflow anomaly. So that's a short axis view for the RBOT. Okay. Okay. So here we go. Here we go. You want to see the tricuspid valve? That's a tricuspid valve. Okay. So that's the right atrium, right ventricle. So that's a tricuspid valve, and here we have the pulmonary artery and the pulmonary valve. So if you want to see tricuspid valve again, you can go into the apical four-chamber view and look at the tricuspid valve. Okay, fine. So that's the RBOT and the LBOT. Now if you take these four views and you add it with the three vessel and three vessel Cartier view, most of the time your screening of the heart is good. So now from the four-chamber view, I'll come up and I see the three vessel view. Okay, so that's a beautiful three vessel view. We have the pulmonary artery which is in a longitudinal direction. We have an aorta which is in a transverse direction, and we have a superior vena cava. And from left to right and from anterior to posterior, we have pulmonary artery, aorta and SVC in a descending order of sizes. That is very important. So the pulmonary artery is relatively larger, then is the aorta, and then is the SVC. So if you see that this, when they are in this way, this is known as normal arrangement, and when they are in a straight line, this is known as normal alignment. So when we look at a three vessel view, we need to look at arrangement and alignment. So typically in a TOF, the aorta comes up and it is not in a straight line, so that is an abnormal alignment. But when you see that the aorta is anterior to the pulmonary artery, that is an abnormal arrangement, and that you can get in some situations like TGA or DORV. So when you look at three vessel view, the three vessels should be seen in this arrangement and they should be properly aligned. Okay? Yes, very good. So we come from the three vessel into the three vessel trachea view, for which we need to do slight oblique turn. And now I am seeing the three vessel view. Okay, I'm in a three vessel view. In a three vessel view, I'm not seeing the vessels. I'm seeing the arches. So what are the arches we are seeing? We are seeing the ductal arch. We are seeing the aortic arch. This is the isthmus of the aorta, and this is the superior vena cava. So in a three vessel view, we can again three vessel trachea, we will call it 3VT rather, and we can switch on color, and now we can see that both the arches are seen very well. So when we take, when you want to screen the fetal heart, okay, for anomalies, if you have a good four-chamber view with color, and if you have a 3VT with color, and if both the views are normal and the sizes are normal, there are very good chances that the heart is normal. And therefore, in the first trimester, very often when we screen heart, we look at four-chamber, we look at four-chamber color, we look at a 3VT, we look at 3VT color. Then, by far and large, you are ruling out almost all cardiac anomalies. That's an excellent view to screen for fetal hearts. Okay, so that ductal arch is an arch where we know that normally from the pulmonary artery we don't want. So pulmonary artery, as it comes out, actually trifurcates into right, left pulmonary artery and a ductal arch. Ductal arch continues and joins. Yeah, that's a ductal arch. That's right. So ductal arch continues into the aorta. And why does that happen? Is because we want to bypass the lungs, which are not yet mature. They are not able to take up the blood. Okay. So now this is how it is. Now we can take additional views. For example, we can take a longitudinal view. There are three longitudinal views which can potentially we can see. We'll see if we are able to get them. One is the aortic arch view. This is another very important view. This is known as a hammock view. Okay. Now this hammock view tells us that the IVC is joining into the right atrium. That's the superior vena cava joining into the right atrium. And if you imagine when you sit in a garden on a hammock, right, you're sleeping in a hammock. This is known as a hammock view. So this view is very good to tell us that the IVC and the SVC are normal and they are joining into the right atrium. Okay. Another two important views which you can see in a longitudinal plane are the arches, the ductal arch and the aortic arch. So let's see. Yeah, we'll do that. Okay, that's a hammock view, beautiful. and then we look at the art. So with this, make the zoom less. Yeah, less. Yeah, okay. Yeah, no, that's okay. Yeah, good. Yeah. Right. Now this is now you can zoom. Once I get the position, you can zoom. Okay. Zoom. Yeah. Now what I'm getting here is an aortic arch. Okay. Go up. Why am I saying it's an aortic arch? Because it's a very sharp arch. It's like a cane. It's like a cane. Okay, it's got a sharp turn. And number two, it has got these vessels which are coming from the top. Can you appreciate these vessels? So these are the vessels going to the neck. So this is aortic arch. The aortic arch is very sharp. Why is it sharp? Because the aorta comes from left ventricle. And where is the left ventricle? It is in the center of the heart. So it has to take an acute turn to come down into the descending aorta. Whereas the ductal arch comes from the right ventricle, and because it comes from the right ventricle, it has to travel a larger distance, and therefore it is usually very broad. It's a broader sort of an arch. So let's see if we can get a ductal. Zoom out again. Zoom out. Yeah, out. So when you zoom out, reduce. Yeah. Chota kara. Yeah, Marathi also we call it chota kara. Same. Word is same here. It's just like little here and there. Okay. So there is a spine. This may be slightly elder, and therefore very often you get a lot of shadowing coming from the spine ribs, but that's the ductal arch. The ductal arch is typically, as I said, it's a wide arch. Okay. Yeah, he's saying TK. Yeah. Yeah, but the baby started moving. Yeah. Now increase the gains like yeah. So I mean I'm not on a very good view. I'll try again. But the point is that ductal arch is a broad arch because the right ventricle is closer to the sternum. So it goes all the way and it goes down into the descending aorta, and we do not get any branches in the ductal arch. Why? Because there are no branches which come from the ductal arch. Okay. So it is basically the pulmonary artery which gives rise to three sort of branches, and it can rather two branches and then it continues as the ductal arch. So just switch on color, maybe we can see color. Pulmonary, when you have an RBOT, it basically divides into right and the left pulmonary artery, and the main one continues as a ductal arch into the aorta. It's a trifurcation, it is not a bifurcation, it's a trifurcation. Okay, term may be different, whatever. Okay, now increase the colors. Color, yeah, quick. So because of the spine, this is the flow across the ductal arch, right? Yeah, that's right. This is the flow across the ductal arch. Someone wanted to do that. We can also measure the flow across the ductal arch. Okay, so you can see it is not sharp like the aortic arch. It is much flatter, and it comes from very close to the sternum. Okay. So we have seen the heart in black and white. We have seen heart in color. And if you want to finish the examination, we can also look at go back to basic, switch off color. We can also do the flow across the mitral and the tricuspid valve. Right? Okay, now zoom. Yeah. So these Chinese words are quite very similar to Marathi words, okay? He's asking me, like, so. Yeah, very good. Word is one, like, We have divided it unnecessarily into different parts. Okay? Little. Okay. Okay, can you change the angle? Yeah, and this side. Yeah, that's better. So that's the tricuspid valve. So we'll try and take up this thing there. Make it invert. Yeah, then it is. Yeah, okay, wait. Now go to real time again. No. Go to real time. No. Update. You have update? Okay, yeah. Okay, maybe you can decrease your width. The volume, yeah. Yeah, small. Now do it. Sample. Yeah, now. You'll get a crisper waveform. Update. Trace. Update. Yeah. Oh, it will move. Okay, we have got it. So this is the waveform across the tricuspid valve. We have the E wave and the A wave. Okay. Now we'll try and see how to look at rhythm. If I get it, Joyti is an expert in that. So if I don't get, Joyti will come and help me. So what we do is we go into the LTOT slightly, and then go into the mitral valve and try and get the waveform there. So that's the mitral valve.
You are joining here? Okay.
Update. It's moving. Can you just show them the rhythm, how you take the waveform? Okay. Yeah, so what we do is we go into the 4-chamber, zoom. Yeah. Yeah, let it be.
So we take a good 4-chamber view and we put the pulse droplet sample in the left ventricle close to the crux of the heart, and now we take the waveform. Crux of the heart. I want increase with speed, fast. Yes.
Very well. Yeah, so we have to increase the speed.
I do that again now. So we put the droplet sample and the sweep speed. Frozen. So if you look at this waveform, this is what I was trying to show you. This particular area, if you look at the 4-chamber view, blood is flowing into the left ventricle across the mitral valve and going out of the left ventricle across the aortic valve. So when it flows into the ventricle across the mitral valve, mitral is M, so it gives rise to a M-shaped waveform. And when it goes out of the aorta, out of the ventricle, it gives rise to a V-shaped waveform. Now, if you look at this M-shaped waveform, this particular wave is because of atrial contraction, and this particular wave is because of the passive filling of the ventricle during diastole. So this is known as the E wave and this is known as the A wave, and this is the ventricular contraction. So if you look at this waveform, every atrial contraction is followed by a ventricular contraction. In other words, the rhythm of the heart is normal. So this is a very good way of figuring out the rhythm of the heart. If you get this waveform, the rhythm is normal. Now, if the rhythm is abnormal, then it's a huge big thing. There is a lot more to be done, which we can skip for now. But there's one more thing I would like to show you. How do you work on the cardiac function? Again, we have the same waveform. I need calculation. Calculation for time. Time. Do you have any time calculation? Time. Time calculation. Okay. So what do is we measure the distance from the end of the A wave to the beginning of the E wave. Okay. So this time, so here the time reads 0.24 seconds or 240 milliseconds. See, here's the time, this is showing the time over here. So what I do is, next I measure the time of the V wave. Okay, so beginning of V wave to the end of V wave. Okay, so this is the ventricular contraction time. So you can see over here, this is come to 0.16 seconds, which is like 160 milliseconds. So then you can calculate this 240 minus 160 and divide it by 160, and that will give you the myocardial performance index. Some of the machines will give you this measurement directly. I don't know whether this machine can do that, but probably they can give the calculation directly. And myocardial performance index is a good measure of cardiac function. Very, very useful in diabetic mothers, where the Dopplers will be normal, but the myocardial performance may go abnormal, and sometimes we have near-term IULPs in these mothers. So when we do a Doppler study for diabetic mothers, it is always a good practice point to do the myocardial performance index as they have shown over here. Now,
Okay. Just take a biology.
Side.
So we have one more question.
So this is a very common thing, when we are doing a scan on a pregnant lady, because of their position, lying down flat on their back, they often feel they get IVC compression and they start feeling
রিপোর্ট দিতে হবে
uncomfortable.
পুরাটা দেখে
So
দিয়ে
the
একটা রিপোর্ট
first
করে
thing
দেওয়া
we need
উচিত
to do is move them onto their left
পেশেন্টটাকে
side.
একটা রিপোর্ট করে দেওয়া উচিত
Side के बाद side होने के बाद better लगता है आजकल.
Is she feeling better?
Yeah. So
Go
immediately
out of it no more. Go out of it no more. Okay. Show them the three basic messages.
So biometrics. Yes. So
Please go on. So when we look at the fetal brain, there are two ways of looking. One is a basic examination and then an extended neuroprogram. So the basic exam consists of three sections. One which Joyti has just taken is the transthalamic view. And in a transthalamic view, we typically look at the biometry. Okay, so here we are looking at a BPD. We will also do an HC, and we can also just point out important landmarks before we move out of this patient.
okay.
Yeah.
So that's the BPD section. We have taken the bilateral diameter, we have taken the neck circumference with the important structures.
Just remove the markers. Yeah.
So
So Still okay? Yeah. So we'll just do that. Yeah.
I think the patient is a little
Sir.
uncomfortable, so I will take the.
স্যার
And then you two freeze.
এই পেশেন্টটাকে দেখার পরে একটা রিপোর্ট দিতে হবে তো একটু ইয়ে করতে হবে
EBS code. No, hospital.
Joyti.
Yes, naturally.
And I told that no, not so crowded inside.
Don't be. You can go. She can also be there.
Yeah,
So more
sure.
comfortable. One page that you can transfer. Also.
AC. Advanced ceremony. No.
Transthalamic view abdomen transventricular view
We are frozen, so we made it afterward. Because she is uncomfortable. We are frozen. Placenta is happy. Those three images. So the patient was uncomfortable. So what we have done is we have done the biometry quickly, and Joyti has frozen three images of the fetal heart, which are the basic views which we take for fetal CNS. Placenta is anterior. And placenta is and anterior, and cervix is within vaginal cervix. Next page. 750 grams. 750 grams. Yeah. No, we just show them the three basic. Okay. One. So what we did is we stored three images. Okay. So when we do look at a fetal brain, we have three important planes. This is known as basic exam. So we have one transdynamic. I'm sorry. Go back to that. So we have a transthalamic plane, and in this plane, the important structures are this interrupted interhemispheric fissure. We have the CSP or the cavum septum pellucidum, and then of course we have the thalamus, and this we typically use for measurement of biometry. A very important structure in this is this lateral sulcus or the Sylvian fissure. So she is around 24 weeks, and this is what we expect around 24 weeks. So we know that normally this angle goes on changing as the operculation goes on upping. So when we go on doing biometry, when we look at a fetal brain, it is very important to look at least this much before to make sure that the cortical development is normal. The second important view is the transventricular view. Yeah. That's a transventricular view. And when we take a transventricular view, Okay. When we look at the okay, so okay. So when we take a transventricular view, our main intention is the ventricular size, right? So typically when we look at ventricular size diameter, we have to do in this view, we always measure the posterior ventricle and we measure it at the level of the parieto-occipital sulcus. And when we measure from the inner wall to the inner wall. So we take the caliper measure, and we measure from the inner wall to the inner wall. This is important. So just like we have guidelines for NT scan, similarly we have guidelines for lateral ventricular measurement. So image should be zoomed. It could be, we should see both sides equal. We measure it at the parieto-occipital sulcus and we measure it from the inner wall to the inner wall. The third important view for basic neurosonogram is the view which we take for the posterior fossa. So in this view, again our main intention, So when we look at this, our main intention is of course important things like the vermis, the cerebellum, the cisterna magna. These are the neural reflections, that's a plate there. These are the next pouch, which is a normal finding. And very often if you take a good section, you can also see the nuchal fold in this view. Now of course here we took them in a hurry, but in each section, that is the lateral ventricle view, the transthalamic view and the posterior fossa view, we should see the CSP in all three sections. This of course we just took in hurry and therefore that is not so these are the three basic views which are used for neurosonogram. And if there is a problem, then we do an extended neurosonogram where we look at coronal and sagittal section. So Joyti will do a transvaginal scan. This patient is hungry and I will go out.
Mandula is coming to holding back.
Thank you, sir.
So in the first place, we need to know the history of this patient.
itu বই কিনলাম একটা ছোট্ট আপনার সামনেই তো কিনছি
So this is a 35-year-old patient who has 2 children. Periods are regular and she is here with us for a pelvic scan, and the best way to do a pelvic scan for a married patient or maybe a sexually active patient is to do a transvaginal sonography. I would like to
কাপড়টা একটু এদিকে দিয়ে কাপড়টা সরাই দিতে বলুন কাপড়টা সরাই দিতে বলুন
ভাই কি বলছেন বাড়ি
Can you please review complete? Complete. That's
এটা কোন কোম্পানির ইয়ে ইডান চাইনিজ চাইনিজ কোম্পানি
চাইনিজ ইদান
হ্যাঁ
ইদান চাইনিজ কোম্পানি
দাম কীরকম এটা মেশিনটা
okay. So what I would do is
খারাপ না তো স্ক্যান
I would, when I put the probe in, when I put the probe in, I
Minute থেকে আমার তো ভালো
decrease
লাগছে।
and put the probe in. Now why so? Because I would like to start scanning the cervix at the outset. So this what we are seeing over here is the
Follicular
cervix.
ইয়েতে
Okay, we can
Nabothian
see
cyst.
one Nabothian cyst over here. Then we go further in. As we go further in, we need to increase the depth.
Urinary bladder
Okay, we need
pressure
to
রয়ে গেছে।
increase the depth so that we are able to visualize the entire uterus. Okay, I'll go back again. So this was the cervix. This was the cervix. And as I move in, as I move gradually in, I'm able to visualize the whole uterus. So we can take the measurements of the uterus over here. That is the longitudinal measurement. Okay. Then we can also take the height of the uterus. That is the anterior-posterior measurement. Now keeping the probe,
অ্যান্ডোমেট্রিয়াম তো
keeping the fundus of the uterus in vision, I'm going to turn transverse. Now as I turn transverse, I can see the transverse section of the uterus. Again, I will take the measurement, right? Now I go back to the longitudinal section and I look at the endometrium. So the endometrium and measure the endometrial thickness from one end to the other end of the endometrium. Now what I like to do is, keeping the probe in the longitudinal section, I am moving towards the right of the patient. And now I am going to scan the uterus from the right end in the longitudinal section. I have come to the midline. I am going ahead to the left. So I have scanned the entire uterus in the longitudinal section. Now I go transverse, I go up into the fundus and I'm moving down until I see the cervix in the transverse section, right? So I have scanned the entire uterus. Now having done this, I go to the transverse section once again and I am moving into the right fornix and there I can see the right ovary. So that's the right ovary. Then once I see the right ovary, I am going to keep the ovary in view and go longitudinal because I need to scan every structure into orthogonal planes. So I have seen the entire right ovary. I can take the measurements. I can take the 3 distance volume if required. Then I go back again to the transverse section and I am going to hunt for the left ovary. Now here the left ovary is like focus. So the left ovary is a little higher up. I don't know how well we are seeing it.
আরও উপরে উঠতে
So
হবে
I need to adjust the focus. So this is the focus over here. You need to adjust this so that it comes to your area of interest. I'm sorry. This is the focus. Down. Here. Yes. Okay. So here, the moment he has moved the focus down, see you start seeing the left ovary. Can you see that left ovary with the follicles over there? So again I can take the measurement. Now keeping the left ovary in view, I am turning my probe right angles so that I have scanned the ovary in two planes. Alright, so that finishes the entire scan of the uterus. She does have an absolutely normal uterus, so we don't really need to do anything.
ওভারিগুলো ভ্যাসেলের মিডিয়ালি থাকে, ভ্যাসেলের মিডিয়ালি থাকে ওভারিগুলো। আমি অনেক সময় ওভারিগুলো পাওয়া যায় না।
She wants to know whether these are those typical Venetian blind appearance of the myometrium. So if you look at it, if you have seen the pictures of the Venetian blind things, and you actually see lines going across the myometrium. What we are seeing over here is this one little shadowing over here, and this is probably coming from one small Nebotian cyst or maybe a vessel or something like that. So when you have the typical Venetian blind appearance, you have it coming from the myometrium completely.
হচ্ছে অ্যাবডোমিনাল ওরিয়েন্টেশন। আগে কিন্তু করতে উল্টোভাবে।
If the patient is there, it will be the doctor. First patient.
এটা ওই যে আবু একটা ইয়ে আসছে না, AIUM-এর প্রেসিডেন্ট ছিল, তার একটা বই আছে। ও তো বিনা পয়সাতে বইটা দিয়েছে স্যার।
একটা পেশেন্ট ছিল স্যার, সরি উই ডোন্ট হ্যাভ।
প্রচুর ডাক্তার আছে।